Welcome to the Physiology Case Scenarios Part 2. Let us start with the case 1. This is a case where an individual was found to be having a rare blood group called Bombay blood group. His red cells were not agglutinated by anti-A, anti-B or anti-H serum. Such individuals have a genotype, genetic makeup of HH and cannot form H substance in their blood. So RBCs do not contain the H substance. The question is, the individuals with H antigen only belong to which of the following blood groups? Bombay blood group, O group, A1 group, AB negative. The answer is O group. Let's explain this case. This was a more rare group where the individual had absent H antigen. This H antigen is present in all blood groups, that is A, B, AB and O. H gene is responsible for this formation of H antigen, which is absent in Bombay blood group. If you look at the chemistry of the antigens or agglutinogen, ABO agglutinogens are complex oligosaccharides. They differ in their terminal sugar. So all groups have H antigen, that is oligosaccharide. The type A individuals, the genetic makeup of type A individuals have genes which add terminal acetyl galactosamine by activating an enzyme on the H antigen. On the H antigen, another sugar is added, that is N-acetyl galactosamine. So in that case, the type is A, H plus this. Type B individuals have H plus terminal galactose. Therefore, the Bombay blood group individuals do not have H antigen. This is the explanation for this. Let's go to the second case. A 30-year-old man needed an urgent blood transfusion and he suffers an acute hemolytic reactions, probably due to an error due to mislabeling. Blood sample has been exchanged. And this occurs very rarely. And this person is admitted to the emergency with hypotension, tachycardia, the signs of shock, chest tightness, and hemoglobinuria. That is, the urine contains hemoglobin. Therefore, the transfusion was immediately stopped and the patient managed. Of course, he recovers. The question is, what is the cause of hemolysis? The cause of hemolysis in this case, is it due to damage of red cells by a bacterial toxin which has entered during the transfusion? Or is it agglutination of red cells by the corresponding agglutinins which have entered by transfusion? Or is it due to cell perforation by cell-mediated immune response by the antigens? Or is it deficiencies, glucose 6-phosphate dehydrogenase deficiency in the individual which caused the intravascular hemolysis? If you look at each of the options, bacterial toxin entering is very unlikely because there is no indication of that and does not cause the damage, hemolysis. It's a hemolytic reaction which is obviously written on the case. So it is must be due to hemolysis of RBC by agglutination by agglutinins. If the A group individual is transfused with the B group, the anti-A agglutinins in B group in sufficient titer may cause red cell damage, but it's not the case actually. It is the donor cells which are damaged. A B group individual, the donor is B group. A individual has anti B. So anti B will damage the B cells. This is what happens. It's not the other way. So the donor cells are damaged by the recipient's agglutinins. The recipient's agglutinins do not damage the donor cells because they are not in high titer. Therefore, blood group O can be given to A, universal donor. So they have anti-A, anti-B. They are in low titer. They do not damage either A or B cells. So agglutination of red cells by the corresponding agglutinins is the right answer. Red cell perforation by cell-mediated immune response by antigen is not the correct answer. It's not a cell-mediated response. It is the antigen-antibody reactions. That is, we have the agglutinins, antibodies, humoral immunity, not cell-mediated. And the fourth one is very unlikely. In a mismatched transfusion, the agglutinins in recipient's serum, as I told, in the recipient serum, react with agglutinogens of the donor red cells. So donor red cells which are administered are damaged. Donor reds are important because the recipient has a large amount of blood. Donor is a limited amount of donor cells are given. If they are damaged, it's of no use, and hemolytic reactions will cause havoc. It may be mild hemolysis sometimes. It may be hemolytic jaundice because of bilirubin, excess bilirubin liberated, cannot be handled by the liver, or hemolytic jaundice. As in this case, it is very severe. It causes hemoglobinuria. Hemoglobin being negatively charged gets, less negatively charged. Albumin does not cross the, albumin and hemoglobin are of same molecular weight. Hemoglobin is less negatively charged than albumin. Albumin is more negatively charged. Negative, the glomerular filtration has a negative basement membrane. So negative negatives are repelled usually. The hemoglobin is more positive. It is attracted and gets into the filtrate. Normally hemoglobin is within the RBC. It doesn't come into the solution. But here it has come into the solution because of hemolysis. Hemoglobin enters the filtrate and appears in urine. Gets precipitated, blocks the urinary tubule, causes ventricular damage, and blocks the other vessels, causes circulatory failure, obstructive shock. They're all fatal if undetected. This is the hemolytic reaction out of mismatched transfusion. Case 3. A 6-day neonate is brought to the pediatrician for development of yellowish discoloration of eyes and skin. Mother noted on the 4th day the icterus slightly worsened for a week, but otherwise newborn is feeding well, bowel movements are normal, urine is normal, no fever, vitals are normal, no distress, fetal distress. Neonatal distress. On examination, slight icterus, oral mucosa, sublingual, slight yellowish tinge, baby skin has a yellow tinge, bowel sounds are normal, abdomen is soft, no tender, not tender, no mass, no megaly, stool is normal color, lab values, almost everything is normal for the infant, liver enzymes are normal. Both mother and infant blood groups are B positive, no incompatibility. So, what is the cause of this jaundice, which has appeared on the 4th day? This is very commonly occurring. It's the physiological jaundice. Hepatic insufficiency ruled out because no evidence enzymes are normal. Only bilirubin is raised. Otherwise, everything is normal. Biliary obstruction is very, very unlikely. There is nothing suggesting that. RH incompatibility, test both be positive. Let's go to the next case, case 4. A 3-week old newborn has been undergoing phototherapy for jaundice that appeared on the first day, as soon as the child is born. The first day. This is different. And phototherapy is given to physiological jaundice. This has not resolved the jaundice, but it is slightly reduced to prevent kernicterus, that is, the staining of the basal ganglia is not there so far. But the serum bilirubin continues to be high even after 8 days, which is very unlikely in physiological jaundice. This jaundice is unlikely to be physiological, yes. So it may be resulting from hemolysis, hemolytic, or it may be resulting from RH incompatibility and hemolysis, and of course pre-hepatic. All are almost same. A, C, D are different forms of hemolytic disease. So it is unlikely to be physiological. So it is more dangerous. We have to intervene. A physiological jaundice does not need any intervention except phototherapy. It's a limited value. So physiological jaundice of the newborn or neonate jaundice thus is not present at birth, develops first week, subsiding. What is the cause of this jaundice? It is due to the immaturity of the hepatic cells to conjugate bilirubin and excrete, associated with the rapid rate of red cell destruction. Fetal red cell count is very high, quite high compared to the postnatal or later RBC count. And because of the hypoxia, in vitro hypoxia, once the child is born, the child is exposed to the normal ambient oxygen, so there is no need of increased RBC. So there is a rapid red cell destruction. Rather, the balance occurs. Red cell destruction occurs, but the production slightly is reduced. So there is a net red cell destruction and liberation of bilirubin. This will not be sufficient. The liver is not able to manage this rapid rate of bilirubin coming from the destruction. So slightly there will be a lag where serum bilirubin rises, unconjugated bilirubin rises. Once the liver cells become capable of handling, the destruction reduces, the jaundice also disappears. This will take a week. Phototherapy is of limited value, sometimes given, converts bilirubin to water soluble lumirubin, so it can be excreted in the urine. So you don't require a conjugation by the liver. Case 5. A 7-year-old girl has been suffering from recurrent infections. These are bronchopneumonia, gastroenteritis, staphylococcal skin infection. Girl was treated with antibiotic each time, but responded inappropriately, not very good results. Recurrent infection, worrisome. Blood count reveals no significant abnormality. Neutrophil function tests reveal normal migration, chemotaxis, and phagocytosis. It was concluded that the ability of the neutrophils to form reactive oxygen species and hydrogen peroxide during the process of phagocytosis is abnormal. This is sometimes there are rare cases of this abnormal phagocytosis. Neutrophil function is abnormal. In that case, the individual is susceptible for recurrent infections. You know that WBC is the first line of defense. Phagocytosis. If the phagocytosis is abnormal and the microbial elimination is affected, the person is liable for infection. So you should know the stages or steps of phagocytosis, how the microbes are ingested and destroyed. Now, in that case, one of the toxic materials for the microbe is the reactive oxygen species or superoxide anion plus hydrogen peroxide plus hypochlorite. All these are very lethal to the microbes. They are formed during the intracellular digestion of the microbes. The question is, which of the five following enzymes involved in the generation of the reactive oxygen species or superoxide anion O2 minus is an oxidant, high oxidant, following respiratory burst, that is sudden increase in the metabolism once the phagocytosis occurs and the neutrophils ingest the bacteria or microbe. The metabolism suddenly increases, oxygen consumption increases. That's known as respiratory burst. Which enzyme is involved in this formation of reactive oxygen? Is it G6 phosphate dehydrogenase, G6PD, or is myeloperoxidase, NADPH oxidase, or superoxide dismutase, SOD? At first, if you do not know the biochemistry of these things, it will be very confusing. Let's go to the let's answer is NADPH oxidase. The explanation is this. Following the neutrophil phagocytosis, that is margination, chemotaxis, actual engulfing, there is a sharp increase in the oxygen uptake by the neutrophils and metabolism is increased, respiratory burst. Along with that, there is activation of the NADPH oxidase, which requires glucose 6 phosphatase dehydrogenase, and NADPH will form the reactive oxygen species combining with H and O2 converted gets converted to NADP, hydrogen, and reactive oxygen species. This is very lethal to the microbes. This is called the first step. This is the first step. So we require reaction 1 catalyzed by NADPH oxidase. The next reaction is the superoxide anion is eliminated by the combining hydrogen to form hydrogen peroxide and oxygen. Hydrogen peroxide is equally lethal. Now this is by the superoxide anion dismutase enzyme CD. It generates hydrogen peroxide H2O2. There's also enzyme in neutrophils called myeloperoxidase. It catalyzes conversion of hydrogen peroxide to the hypochlorous oxide, hypobromous acid, combining chlorine, bromine, fluorine. HOCl, hypochloric acid, is also very powerful bactericidal. So all these reactive oxygen series, hydrogen peroxide, hypochlorous acid, are all form what is known as a killing zone inside. So there is intravascular killing. Along with several other enzymes released from the neutrophil granules, lysozymes and other. So entire neutrophil surrounding tissue, everything is damaged. So this is the phagocytosis, first line of defense for bacteria. Next case, a 62-year-old man admitted with extreme fatigue, abdominal pain, loss of appetite in 1 month. Yes, deep jaundice. Bilirubin 14 milligram per deciliter, very high. Vandenberg test is direct positive. Investigation reveals complete obstruction of common bile duct by pancreatic growth undetected. Which of the following substances would be absent in the urine in this individual? Obviously, the complete obstruction, bilirubin is not converted, it doesn't enter the gut, so it doesn't form the urobilinogen. But bilirubin will appear in the urine because of regurgitation, while salts will regurgitate, appear in the urine, all water soluble. Urobilinogen is also water soluble, but is not formed at all. So, and if when it is formed, normally it undergoes intrahepatic circulation, some escape into general circulation. So there is always some amount of urobilinogen urine. If it is absent, it's not normal. So it is absent or very reduced in complete obstruction, biliary obstruction, obstructive jaundice. So both urobilinogen and urobilinogen is not the correct answer. So it is the urobilinogen is absent. Stercobilinogen is absent in the stools. Both are same compounds. Mainly it is excreted as stercobilinogen. Some amount of urobilinogen in the urine. Case 7. Similar. Diagnosed with obstructive jaundice, impacted gallstone. So both are very common causes of obstructive jaundice. Cancer, pancreatic head, which obstructs the second part of the duodenum, where the bile duct is common bile duct is drained, or impacted gallstone in the common bile duct. Both will prevent the inflow of bile into the second part of the duodenum. So there's a backflow, regurgitation. Plasma bilirubin is high, conjugated, 8 milligrams, not as high as in the previous case. And because of the absence of stercobilin, pale stools, foul smelling because of the absence of or deranged fat metabolism. Bile salts are not entering into the gut. Fats are not digested. So fat steatorial with foul smelling, large amount of pale stools. Pale is very important for here. The question is elevation of plasma bilirubin is due to inability of the liver to conjugate bilirubin. Unlikely, because liver is normal, only obstruction in the common bile duct. Increased conversion of bilirubin to urobilinogen. Bilirubin is not entering the gut, so there is no question. Regurgitation of conjugated bilirubin, that is the correct answer. Decrease enterohepatic circulation of urobilinogen. Urobilinogen is not formed at all, so it's very unlikely. So regurgitation of conjugated bilirubin into bloodstream is the correct answer. Let's look into the obstructive jaundice by image. This is an illustrative diagram of how unconjugated bilirubin enters the liver. This is the liver, gets conjugated bilirubin enters the gut and gets converted into the urobilinogen, and some amount gets normal. We will not bother. It's assumed that you know what's happened here. Obstruction of the bile, whether here or here. So there is conjugated bilirubin. This is obstruction somewhere here. Bile duct and flow into the second part of the duodenum is abnormal. Conjugated bilirubin regurgitated in plasma gets into the urine because water soluble, protein unbound, gets filtered. Normally bilirubin is absent in the urine. Bile salts also are absent in the urine. Both will come into the urine. Of course, the stercobilinogen is not formed, it's not absent. Normally it is present. Urobilinogen is normally present, here it is absent. Features: Vandenberg test is positive as said in one of the cases. This is the method of plasma is taken, diazo region taken, then combination. It is added to the plasma. Plasma gives a color. In indirect positive, you have to add alcohol to get the positive. So that will be indirect. This is one feature. Direct Vandenberg test. Bilirubin is conjugated water soluble unbound, appears in urine. Stools are pale, we already. Fecal and urine stercobilinogen decrease absent. These are the key features of obstructive jaundice. Of course, plasma alkaline phosphatase is increased because excreted by the liver. It's not shown here. Case 8 is another case of jaundice. Pale stool, high colored urine, loss of weight, fatigue, fairly young woman. Icterus, enlarged liver. Oh, here there is an enlarged liver. In addition to jaundice, pale stools. Bilirubin is 4.2 milligram. Bilirubin direct 3.8. So mainly direct. Serum transaminase level, AST, ALT level, which are indicative of liver function, are elevated. So liver obviously must be affected. So something to do with the liver now. Liver biopsy reveals inflammation of the portal tract, or some amount of hepatic inflammation. Fatty liver is there. One is likely to show. So here it's the problem with the liver. So shall we call it as hepatic jaundice? But why pale stool? I does look like obstruction. Yeah, pale stool means obstruction. The woman is likely to show, also likely to decrease serum alkaline phosphatase level. Should be increased because if it is obstruction, it is increased. Elevated urine bilinogen. No, it is not hemolytic. It is hepatic. Going on to post-hepatic. It should be absent or decreased. Presence of bilirubin. Yes, this is the answer. Increase albumin globulin ratio. It should be decreased. In fact, increase albumin globulin ratio is not. It's the reverse. Hepatic failure will result in Ag ratio being reduced. Albumin, which is synthesized by the liver, decreases. So it must be C. Presence of bilirubin. Let's look at the hepatic jaundice. The same diagram. Conjugation in this case is there. This is normal. Normal. The problem is here, somewhere here, either conjugation or excretion. So three steps. The conjugated bilirubin enters the liver cells, conjugated and excreted. These three may be affected. Biochemically, there are three abnormalities, either in the entry in conjugation or in the excretion. So let us not bother about this. Is a hepatic jaundice, which is probably due to some obstruction. So features, let us this little complicate hepatic jaundice because it depends on severity. Bilirubin that is excess in this case, unconjugated or conjugated. Initially it is unconjugated, more like hemolytic. It may not be properly conjugated, so it becomes unconjugated. If it is conjugated, not excreted, the bilirubin will be conjugated. Early stages of hepatic jaundice mainly unconjugated since there is less hepatic uptake of bilirubin or less conversion into glucuronide. Late stages, there is if the hepatic problem or inflammation becomes more severe, swelling of the hepatocyte causes intrahepatic biliary obstruction. This is intrahepatic, not extrahepatic as we saw in the previous case. This also leads to conjugated hyperbilirubinemia, looks more like obstructive. So initially bilirubin will not appear, it's more like hemolytic. Then it appears. Urobilinogen is present in urine initially. Later, when there is obstruction, it disappears. And recovery appears. So bilinogen is a good guide to the recovery. Initially present, later disappears, reduces, disappears, then reappears only on recovery. Liver functions are obviously abnormal, as you have seen. Just to finish off this case, the case in question describes a patient who is suffering from hepatic jaundice with evidence of hepatic dysfunction, as evidenced by the elevated transaminase levels. with intrahepatic biliary obstruction. Conjugated bilirubin, water soluble, gets excreted in urine. Biliary obstruction, serum alkaline phosphatase is also increased. Urine bilirubin concentration is decreased. Hepatic dysfunction causes decreased or reversal of age ratio. Case 9. A medical student complains of nasal stuffiness and slight breathlessness. He reports that he gets such a headache on the onset of every winter, allergic in nature. On examination, he has bilateral wheeze. Symptoms are attributed to the release of histamine from mast cells. Which of the following immunoglobulins is responsible for such inappropriate immune response? Allergic responses or hypersensitivity reactions are mainly mediated by IgE reagents. Immunoglobulin E variety is the answer. Case 10. A newborn baby is born to a young Rh positive mother. Develops pallor in 2 days after the delivery. No actress. Physical examination otherwise normal. Lab studies. Infant is O positive. Hematocrit 38. Reduced. Reticulocyte is high. Slightly high. Entry of fetal blood cells into the maternal circulation before or during delivery was suspected. This is called feto-maternal transfusion, which is very, very unlikely. Normally, it doesn't occur. From the fetus to the maternal circulation, there is a blood transfer of blood, and this will dilute the fetal blood to cause the anemia. The newborn's anemia is unlikely due to the consequence of ABO incompatibility. So, even if you suspect ABO incompatibility, it is unlikely. Why? Even in Rh incompatibility, there is feto-maternal transfusion. Transfusion. There is severe reactions. Here, there's not much of change. No jaundice, slight anemia. Why? O positive newborn is O positive already. Lacks agglutinogen A or B to sensitize mother's immune system. Yeah, if the maternal transfusion, fetal-maternal transfusion has occurred, the O positive newborn cells do not trigger any immune response in the mother. There is no formation of antibodies because it has no A, no B. This must be the answer. Agglutinins anti-A and anti-B in the newborn are in low titer to cause agglutination. In fact, anti-A and anti-B are formed after birth. They are not formed in the fetal life, so there's no question of this. And even if they are in, this is a very unlikely choice. The immune system in the newborn is not fully developed to cause antibody formation. Why antibody should be formed in fetus at all? It's also very unlikely. ABO agglutinins and IgG in nature and cannot cross placental barrier. ABO agglutin or IgM in nature. Even if there is some amount of formation of agglutinins by transfer, they cannot cross. So ABO incompatibility is very, very rare. Unlike Rh incompatibility, let us say mother is B, fetus is A cells if at all enter, mother forms anti-A. Anti-A, they are large molecules. They cannot IgM in nature. They cannot cross the placental barrier. So these anti-A or these antibodies cannot harm the child at all. So ABO incompatibility very abnormal, very uncommon. So this is the answer. O positive newborn lacks agglutinogen A or B to sensitive. So O positive is supposed to be a universal donor for this reason. So for you can give it to anybody. provided other blood groups are taken care. Explanation: mixing of maternal blood with fetal blood is uncommon but can occur to some extent during labor. That's the cause of the Rh incompatibility. If Rh positive cells enter the mother's circulation, the specific immune response is stimulated against the foreign antigen. This is in case of Rh incompatibility. The mother is sensitized. This is a different story. Here it's not that. In this case, O positive cells have probably entered the maternal circulation. Immune response is not triggered at all since red cells lack ARB agglutinogens and consecutive ABO incompatibility is unlikely. As I said, ABO agglutinins are AGM nature, even if they are formed by some other incompatibility. They cannot cross the placenta. And as I said, agglutinins and anti-A, anti-B develop only after birth by exposure to food and other substances, not inside the fetal intrauterine life. The learning objective: agglutinogen, agglutinins, ABO blood group, placental transfer of agglutinins. Then you come to the last case, case 11. Rh negative. A 20-year-old pregnant female is admitted for labor pains in full term. The first, probably it is the first pregnancy. Administering anti-D antibodies is contemplated, sort of, soon after the birth of the Rs positive baby with normal birth weight, and no evidence of pylorictus. So the first child is born normally, but she has to be given anti-D antibodies because she is negative. Question is, which of the following would be the function of such antibody? Why you should give at all anti-D? Options are neutralization of Rh agglutinins in mother. Rh agglutinins may be formed because if there is a transfer of red cells from fetus to the mother develops Rh agglutinins. That is true. But anti-D antibodies are themselves agglutinins. They cannot neutralize another agglutinin. It's unlikely. Not a correct answer. Prevention of antigen entry into the fetus in subsequent pregnancies. This is also unlikely. Antigen entry from where? From fetal. So mother to fetal. Mother is Rh negative. Even if some negative cells come, nothing will happen. Rh positive baby, nothing will happen. Prevention of active antibody formation in mother. This is the correct answer. Because once the positive cells enter the mother will be sensitized and active antibody formation occurs. So second pregnancy, subsequent pregnancies, immunological memory will trigger rapid antibody formation. They'll cross the placenta because Rh antibodies and IgG, they easily cross the placenta, and this is the cause of erythroblastosis. It is seen in another module. This case is discussed in other module. Destruction of Rh agglutinins in fetus in subsequent pregnancies is also nothing. This agglutinins cannot destroy the agglutinins. So the answer is prevention of active antibody formation. That is the rationale. Mother should not be sensitized at all. The Rh positive cell should be destroyed very soon because the cells only enter at the time of delivery or at the labor. So immediately as soon as they enter, you destroy them and prevent the antibody formation.